So in vesico-bullous disorders, it's important to understand the level at which the blister is occurring, okay, within the epidermis or the dermis. So here is a simple diagram which shows us the layers. First you have the stratum corneum, which is the topmost layer, and you can see marked here is the granular cell layer below that. So the stratum corneum, which is the outermost layer, superficial layer. Second is stratum lucidum, which is thick in the palms and soles. Then is the granular cell layer. Below that is the spinous layer. So that mid-epidermal level is the spinous layer, and it extends till the suprabasal level. Okay, that's the lower spinous layer. And the last is the basal cell area. Beneath that you have the basement membrane zone separating the epidermis from the dermis. So that's divided into lamina lucida and lamina densa. And below that you have the sublamina connective tissue. So this is an important chart. This shows the level of the blister within the epidermis and the important diseases at each level. So in the granular layer, that means superficial blisters, most important are pemphigus foliaceus and pemphigus erythematosus, which is a less common variant of pemphigus foliaceus. In the spinous layer, lower down in the spinous layer, that's the suprabasal layer, most importantly pemphigus vulgaris and a variant of it which is called pemphigus vegetans. And at the basal layer of the epidermis, most importantly erythema multiforme and its most severe form, toxic epidermal necrolysis or Stevens-Johnson syndrome. Coming lower down to the dermo-epidermal junction, blister can form at the level of lamina lucida or the sublamina densa. So you just need to know the common diseases, that is bullous pemphigoid, which is subepidermal split, and another rare variant of it is cicatricial pemphigoid or scarring pemphigoid, and epidermolysis bullosa acquisita again, which is a subepidermal blister. So a subepidermal blister is always tense, and intraepidermal blister would usually be flaccid. So here now they reveal the common diseases again with the level at which the blister forms. So most superficial will be pemphigus foliaceus, causing flaccid blisters. Deeper down you have pemphigus vulgaris and toxic epidermal necrolysis, and the subepidermal blister would be bullous pemphigoid, which is a tense blister. So I'm going to show you a few photos and descriptions of these important vesico-bullous conditions. We're starting with the intraepidermal lesions or the superficial blisters, okay, flaccid blisters. The first is impetigo and its variant, which is bullous impetigo. So as you can see here, there are perioral lesions. These are honey-colored crusted lesions, and you can see that is overlying a raw erythematous base. So impetigo is a superficial bacterial infection. Causative organism is Staphylococcus aureus or group A streptococci. It's most commonly seen in young children. So you have an erythematous papule which becomes a vesicle or a pustule, and that ruptures, leaving behind the honey-colored crust. In bullous impetigo, it is Staph aureus, which causes a toxin-mediated split in the epidermis. So the toxin cleaves desmoglein 1, which is within the epidermal cells, and that causes a flaccid bullae to occur, which usually gets filled with pus. So the treatment for bullous impetigo is usually dicloxacillin, first generation cephalosporin, and topical mupirocin. Okay, here's a question. The causative organism for the condition depicted in the image is Staphylococcus, Streptococcus, Actinomycetes, or Candida. So this is a staphylococcal scalded skin syndrome. You can see here there is superficial blistering, which has caused erosions, and it started periorificially, that's around the eyes, nose, and the mouth, as well as in the flexures. The baby is looking distressed, so obviously the skin is quite tender to touch. Baby is probably febrile. This is Staphylococcus scalded skin syndrome. So this is also known as Ritter's disease. It occurs in young children, and it's due to the epidermolytic toxin of Staphylococcus Fmge group 2, which attacks the desmoglein 1, which are the connections present within the epidermal cells. And the clinical presentation is a very acute onset tender erythema on the skin, and this rapidly develops to form superficial blisters. And these, as I showed you here, are periorificial and in the flexures. So these rapidly desquamate, and then it causes fissuring around the eyes and the mouth. So SSSS is another condition where you'll get Nikolsky sign positive. Other common conditions are pemphigus vulgaris, and treatment is penicillinase resistant penicillin. This condition, because it is superficial blistering within the epidermis, it heals without scarring. So this is important to remember. Intraepidermal lesions usually will heal without scarring because it does not cross the basement membrane zone. It does not go deeper than that. Whereas subepidermal conditions will commonly heal with scarring. This is a frictional blister. It's an intraepidermal blister. So it's a superficial blister, and it commonly occurs at sites of friction, as you can see here on the sole of the foot. So that's easy to identify. So this is pemphigus foliaceus, which causes blistering at the subcorneal layer. So these are superficial blisters. These are always flaccid blisters. Here you can see the patient's face. So you actually don't see blisters, you see mainly scaling or a crust, which is overlying a reddish erythematous base on the skin. In the next photo, you'll also see the upper trunk of the body involved. So here again, you do not see actual blisters. The blisters actually erode very rapidly. They desquamate and they leave these crusted lesions on reddish erythematous bases. So in pemphigus foliaceus, you'll have shallow or flaccid blisters which rapidly evolve to leave behind crusted erosions. It's a localized disease and it's not so severe. So it usually involves head, neck, and the upper torso. And mucous membrane involvement is very rare. So pemphigus foliaceus typically involves only the skin. The antigen is desmoglein 1, which is present on the epidermal cell walls. So the antibodies in pemphigus foliaceus target desmoglein 1, which is interepidermal connections. There are two variants of pemphigus foliaceus, lesser common varieties. These are pemphigus erythematosus and Fogo-selvagum, which is an endemic type of pemphigus foliaceus seen in the Amazon basin. On histopath, you will have intraepidermal acantholysis, as I said, and this is subcorneal, below the stratum corneum. That means superficial layer. And direct immunofluorescence, or DIF, will reveal intercellular antibodies in a net-like pattern, in a fishnet pattern, and this is restricted to the superficial epidermis. So I'll explain a DIF in a little while. This is pemphigus vulgaris. So here you can see there are flaccid blisters, some filled with pus as well, and there are extensive eroded areas. So these blisters have given way, the roof has been eroded, and you can see the underlying raw epidermis. There is also hyperpigmentation. You can see a purplish tinge. That is the lesions which are reepithelizing, and they heal with hyperpigmentation typically. Here there is quite extensive involvement. So pemphigus vulgaris is a more severe disease. It usually involves the torso, head and neck as well, and it can involve the mucous membrane. So oral involvement is quite common as well, oral mucosa. Eyes and genitalia can also be involved. So here again you have flaccid blisters which eventually form widespread erosions. Involve skin and mucous membranes as well. Pemphigus vegetans is a variant of pemphigus vulgaris. This occurs in the skin folds and they form vegetating granulations. It's less common variety. The antigen in pemphigus vulgaris is mostly desmoglein 3 and less common desmoglein 1. Okay? These are again the intercellular connections in the epidermis. On histopath, you will have a suprabasilar blister because this is in the lower epidermis. So just above the basal layer, you'll have acantholysis, and this forms a tombstone appearance of the keratinocytes which are left behind on the basal layer. I'll show you that in the next few slides. DIF will show the intercellular pattern again of antibodies in a fishnet pattern, and this is usually throughout the epidermis. I'll show you the photo again in the next few slides. So this is also pemphigus, which involves the oral mucosa. You can see denuded areas on the tongue as well as the eye. So you can have permanent damage to ocular mucosa in pemphigus vulgaris. This looks like pemphigus. This is a toxic epidermal necrolysis. So you can see the patient's face. There is oral and eye mucosal involvement. As you can see, there's already some, you can see some discharge from the eyes, and the eyelashes have matted, so that's obvious that there's eye involvement as well. Oral involvement, you can see the reddish and the sort of, you can see at the lip margins as well, they're involved. The skin has just been peeling off. So you can see it's very superficial layer of blister involving the face and the body, and you can see it's become quite confluent, so the skin peels off very easily to touch or to any pressure, and you can see few areas of normal skin involved, normal skin left in between the involved skin, that's on the trunk. So this condition has a high mortality rate. And in this kind of condition, of course, this requires ICU care in most conditions, temperature regulation because of vast, more than 30% body surface area involvement, monitoring fluid intake and output as well. Protein intake is very important, and kidney functions should be monitored as well.